Okay, ma. Good evening, all of you. So, I welcome all of you to this session or practice session by Target MRCPCH. Today, we will try to do one communication, one video, and maybe one development station. Before starting, okay. So, I request all of you to just look into this website where recorded videos are available. So at affordable rates, targetmrcpch.com. We have a free course, which is just a token rate is there. So all the videos which we have done so far in YouTube, everything is compiled in this clinical free course. Also, we have a crash course, intensive revision course, so all at affordable prices. So you can download the app and start subscribing and start using it. So it will be a useful one. So those who are just want to look into the videos and just started preparation. So these videos are will be very useful. And for iPhone users alone, it asks a organization code. So you can request that. I will just put in the chat that organization code XRQUWD. So iPhone users alone have to put this organization code, and abroad users other than Indian can use email login if you have difficulty with the mobile phones. Okay, so with this we will start our mock. Okay, so I think I got a message from Dr. Lakshmi for communication. Dr. Lakshmi, are you there?
Yes, sir.
So you can note down this, Doctor.
Okay, sir.
Take. Okay, so take 3 minutes time. You can take the mother's name as Lisa.
Okay, sir. Sir, what is the current age of James?
I think whatever information you can take
Okay.
in this case. Okay, doctor. Okay. That.
Okay, sir. Okay. So I enter the room. I hand over my mark sheet to the examiner and wish him. Hello, I'm Dr. Lakshmi. I'm one of the newborn doctors here. So am I speaking to Lisa, mom of 14-day-old James?
Yeah, doctor. Yeah, you can call me Lisa.
Okay, okay, mom. Okay, Lisa. So I am here to talk to you about James. Is this a good time for you?
Yeah, doctor. Yeah.
Okay, and do you want somebody to be accompanying you while we are discussing?
Yeah, I'm okay to be alone, doctor. My husband has gone outside. You can continue.
Okay, Lisa. Okay, Lisa. So, have anyone told you about James' condition so far after coming here?
I'm not sure, doctor. Like, I don't know. You people keep on moving here and there. My baby, I don't know what's going on. No one has told anything.
Of course, Lisa, we are here to discuss the same. So, I would like to know, like, um,
Doctor.
hello, sir. Hello.
Got it.
Yes, sir. Yes. So, I am here to discuss to you about James's condition. Okay. So, first, I would like to congratulate you on the baby. How are you doing, mom?
I'm not in the mood to get congratulations, doctor. Like, I'm frustrated. And see, you are moving from one cubicle to another, and now you are saying you have to shift. And now what you are going to tell, I don't know.
Okay, so Lisa, there is something we found out. Like when a baby comes from a different hospital, we take some surface swabs, which we take in a cotton and we culture it, and we found that in James's case, two of them came to be positive for a bug,
Bug?
and it is yes, 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 Lisa.
What bug,
So
doctor?
yes, so this is a bug called MRSA. Have you heard of that?
Uh, you mean this super bug?
Oh, you are well aware of that. Okay. Yes. So it is called a superbug. And since,
How did,
as the name
how
states,
did he even get it, doctor? Is it from
okay.
your
So
hospital, this super bug?
actually, Lisa, even we have seen it can be from hospital, as you told, but it could be from outside also. We have seen babies and children who are admitting newly coming from the community having this positive.
I,
Are you
I
with me?
I didn't come from any community, doctor. I have been in your hospital till last hospital. He was fine, and now you are saying some bug is there. I'm not happy, doctor.
Okay, okay, Lisa. So I understand your concern, and it has been difficult for you because you have been taking good care of your baby, and still a lot of things are, troubling you. I can understand that, but this is a fact that this is positive for James, and it actually it transfers even from touching and handling babies, and also it could be from other babies, or it could be from people from outside also.
That's what I'm saying. You people are not taking care. You yourself saying for touching and spreading. Why don't you take proper precautions? Why don't you do proper hand wash and take care of my child and see my.
Actually, yes, yes. So we are doing actually hand care. We are extremely careful with baby handling newborn babies, but sometimes it happens. So when that is there, then we have to take extra precautions. That is why we are isolating as babies with this kind of bug.
So why you want to isolate, doctor?
Yes, sometimes this can happen in people who are healthy and they may not have any problems with the bug. But sometimes when the babies are having some kind of illness and they get this bug, and maybe it causes a serious illness in them. So that is why we are kind of careful in this situation.
So you mean to say that my son is going to become sick because of this bug?
Lisa, as I have said, sometimes see it could be normally seen in people also without any illness. Sometimes it causes infection, sometimes it may not cause. So it is not that all cases, all of the time, all the time it should cause an infection. With me, are you with me?
Uh, I'm really worried, doctor. So now my child had to go through all this surgery and all. So 2 weeks of suffering, and we wanted to go home. And now you are saying super bug, and you say he might worsen. I'm really scared.
Yes, yes, I can really understand the situation that you are in, and like you are like any other mom who will be worried in the situation. So, but let me assure you certain things. Like we have a treatment for this bug, and if you are following it diligently, and then we can actually get rid of the bug completely from the baby.
So how you are going to get rid of this stuff?
Yes, of course. So what we do is with the procedure, what we do is called decolonization. So where we are removing the bug. So what happens is we give a solution which should be rubbed onto the baby's like from head neck downwards. And also there is another cream ointment that you have to put in the by the side of the nose, not really deep but in the front of the nose and by inside also a little bit. So when you do that 2 times a day for the next 2 weeks, so we can really eradicate the bug. Uh,
So how long? It's like 2 weeks. I have to stay here for 2 weeks.
Actually, no need. Like we can, you can. I will discuss with my consultant regarding the discharge of the baby. But before that, I would like to tell you that 7 days is the minimum that we have to do. And following that, we will actually take the baby swab once again. And in between also we will be taking. But afterwards we will take in the end also, and we make sure that that is I said no 2 weeks. Then we make sure that the bug is not there.
What else, doctor? So how what precautions I should take care?
Yeah, like since you're the one
Can
handling
I
the
uh,
baby,
can I touch at least my baby? Feed my
of
baby?
course, like you are already taking care of the baby, so you can touch the baby. Only thing is you just have to be careful with your hand hygiene. Yeah, we will actually train you in actually hand hygiene, and also we will train you in doing the applying the medications for the baby. Is that is that okay?
And will anything bad happens to my baby?
Lisa, I understand your concern. So we all are hoping for the best. So if we do it diligently, the hygiene and the medicines, we can eradicate or completely remove this bug, and your baby will be safe.
Okay, so do take care at least.
Y- Yes, yes. I didn't hear your query.
Please do as early as possible and discharge at the earliest. My son has suffered, gone through a lot.
Of course, Lisa, we are looking into him, and right now he is stable despite the bug being positive. So that's a very good news. And he is not actually, the bug can be there and it may not cause a disease also, but we have to make sure that we completely remove the bug from his body. So that is why we have talked to you so much about the bug. So, and also I would like to inform that we will be monitoring the baby for any of the clinical features like associated with the bug infection, and also we will do cultures like on particular every 3-day gap, so that those days we will inform you prior and we will let you know also.
Please
So
do
mean
that.
yes. So meanwhile, you can feed the baby because baby and give all the other care for the baby as like any as like in any day. Are you with me?
Yeah. Take time
Okay.
up.
So
You can
9
summarize.
minutes over. Yes, yes. Okay. So Lisa, so I have told a lot of things for a single sitting. So we may need to discuss about this more in detail over another sitting where I'll come back to you, and by then you can actually have collect your thoughts and doubts, and you can ask me on further clarification of those doubts also. Are you
Sure.
with me?
Thank you, Doctor.
So meanwhile, yes, yes. Meanwhile, I would also like to give you some leaflets so that you can read more about the bug and have a better idea also. Is that okay for you?
Thank you. Thank you. Okay, Doctor. Time up.
Okay. Okay. Thank you.
Okay. Lakshmi, how you did?
Ayo. Yeah, so I thought it was information giving, but the mother was very upset when I told her congratulations on the baby. So, so when should we congratulate the mother and when should we not, sir?
Hey, man, you should look into the tone of the mother. No?
Yeah,
So
but if
she started actually. I don't know, doctor, how when you are building the rapport, no, how are
mm,
things going on? I don't know, doctor. You people keep on testing and moving my child here and other. I'm kind of worried, no. So there,
mm,
she is a bit upset. So that you have to pick up that. Look,
mm. Suppose that we accidentally made a comment like this, and then the bystander says, "Don't do that." So will I be marked down for that?
yeah, but it's okay. You overall conversation they will look into it, doctor, rather than a single point. So
Okay.
you didn't knew that she's very angry or upset. But if it is a
Yeah.
breaking bad news, she's already sad. No, so child is suffering from some disease.
Mm,
You know
mm,
clearly. No, there when you
mm,
talk congrats, no, that might be inappropriate. Right?
mm,
Here
mm.
you don't know that mother is angry and all.
Okay.
Okay. So any other points you felt like you could have done better?
Sir, the guidelines says like hand hygiene as well as decolonization regime. No, anything else should I add here? Like feeding also, I said. Anything else? Should I
Yeah.
elaborate on the disease of the baby? Like red flags, should I tell here?
Yeah. Here I think hand hygiene and decolonization is the main thing that you have to concentrate.
Mm-hmm.
And maybe you could have discussed about colonization and infection. So that
Oh
different
yeah. Uh-huh.
could have told.
Yeah.
She is
Mm.
very worried. She has learned something about MRSA, superbug. So she is worried and
Mm.
so you have to tell the difference between colonization and infection. So
Yes.
colonization means the bug is on the skin and it has not entered, and at present the baby is fine. It will not affect the baby. Infection is one when it enters the body and causes problems like fever and dullness, uh, like that. So that only we need
Mm-hmm.
to be worried, and good that we picked it up now itself, and we will try
Mm.
to remove the bug by the steps which you told actually.
Yes, sir.
Okay, so I think Dr. Shaheen has to say something.
Yes, yes, sir. About the discharge. So I didn't know that exact time when we will discharge.
Okay, okay, maybe Dr. Shaheen can talk up. She has something.
Yes, sir. My query is that the if the similar child is if the similar scenario and they just said that this child is about to discharge. So so what to do in that case? Do we need to decolonize at a home? Does it require because he has undergone any surgery? Definitely, we will discharge this baby once it was like all of the wounds are healed, but still there is some stitches lying there. So does it require any decolonization at home? Or maybe delaying in the discharge or something like that.
Yeah, as such, in the guidelines, it say that mainly the MRSA is for preventing the spread to other babies. So, the babies which are very fragile and here I think the wounds are healing. It's written the wounds are healing. It's almost 2 weeks from surgery. So unlikely that when the baby is about to be discharged, unlikely that it will be a harm for the baby as such. So I think Dr. Lakshmi also for no. So the main concept of isolation is to prevent the spread for other babies.
Yes, yes.
So if you are going to get discharged, no, so then we need not decontaminate actually. As per the guidelines, if you
Okay.
are taking the baby home, so then we need not do the decolonization protocol. As long as you are in the hospital alone, you have to do the decolonization. So if you're going
Okay.
home, then we need not do. So till you are going
Mm-hmm.
home, then we have to do the decolonization. So you can look into the
Okay.
guidelines what they say. So they say if you're going home, you need not do it because it can be there. Even the
Mm.
30% of the anyone can have MRSA. So we don't eradicate
Mm.
everybody. So why we are eradicating is because there might be a preterm baby, there might be a fragile baby. So they can get this bug, and so that's why we are isolating and we try to decontaminate as long as the baby is in the ICU. So till the
Okay,
child
sir.
gets
Mm.
decontaminated, we have to keep the baby in the isolation. Okay.
Mm-hmm.
And maybe
And
the
sir,
ah,
if he is right now, sorry sir to interrupt you,
yeah,
if there is a similar child is right now in the hospital, so regarding this, regarding the decolonization in this child, do we need to say that we will definitely do the decolonization, or do we need to say that
yeah.
we will involve the microbiologist and as per their risk assessment, we will do, later on
No,
we will
if
decide.
the baby is in the ward, you are isolating the baby. So how long are we
Hmm.
going to isolate? The baby has to go to the regular cubicle. No, we cannot be isolating for a long period. So as long as the baby is in the ICU, you have to decolonize the baby, and maybe you can say I will discuss with the microbiologist regarding the full protocol. But we will be decolonization. You have to tell, and what decolonization procedure you have to tell. So we will be giving the antiseptic lotion, and we will be giving the ointment for the nose. So that, and the decolonization actually is for 5 days, Dr. Lakshmi. It is for
5 days.
5 days.
Okay.
Yes, 5 days.
You do it
Mm.
for 5 days, and swabs will be almost 5 to 7 days once. Three consecutive swabs have
Three
to
swab.
be negative. So till then
Mm.
they will not stop the isolation. So as long as in the
Mm.
ICU, NICU, you have to isolate. Three swabs has to come sterile. Then only the baby will be let with other babies. Or if
Mm.
the baby goes home, then you need not do this swabbing and decolonization. You can stop also if the baby is going home. So you can do a maximum 2 times decolonization, not more than that. So that is what it's written. So I think they are checking here how you are addressing the anger of the mother. Okay.
Mm.
And the second is how much you know about MRSA and this decolonization. So they will be expecting whether you are talking about infection and colonization and the
Mm.
baby is colonized. You have to reassure actually. That reassurance only at the end you told. You have to reassure straight away that don't worry that your baby has superbug. It is not infection. It is actually colonization, which means it's only on the skin and the baby is not having any problem. The baby may not have any problem. Baby is fine and good that we picked up. We are going to decolonize. Okay, so
Okay.
others have raised their hands. Dr. Saravanan, you can tell Dr.
Sir, is it okay to give a comment or we'll continue because mock session, a lot of people are
Yeah,
there.
yeah, yeah, we are free only. So, can give
Oh, okay. So, one thing is, sir, as Dr. Lakshmi said, she started like an information giving scenario and then it changed. We suddenly found that the mother is an angry mother. Same thing happened in the Chennai mock also for neonatal jaundice. So that was also kept like that. So in this case, a small suggestion. So when things they suddenly the parent come on us, instead of chasing them and trying to make them calm, so we can put a break and tell them that I can see that you are clearly upset, but I will take you through this step by step. And you have any doubt anywhere, you can always stop me. Like that, we take some time, we take control, and then we proceed. It would be become easier. Because we also don't expect it, whether it is an angry mother scenario or it is a information giving scenario. And suddenly when this comes, we should not show that we are getting perplexed and we are also getting confused. Instead of that, we can buy time by saying that. That is what I felt when she was presenting.
Yeah, yeah.
Yeah.
And actually, they are expecting that only. So whether you're calming the mother, actually, I can you didn't Lakshmi, Dr. Lakshmi, you didn't start initially about I can understand your frustration. So something like
Mm-hmm.
that,
Yeah.
you have to reflect on her issue.
And
Emotions.
Other thing is, sir, the scenario gave extra points like the child is recovering well and going to be discharged, all that. So we could have used that information to
Yeah.
start the conversation. We are very happy that he has come out well after the surgery, all that. So that information sometimes, when
I
they give
think
extra.
Dr. Lakshmi was asking about the rapport building. No, she was congratulating. No, so I think this lines, as Dr. Saravanan says, you can use those words. So rather than
Mm-hmm.
almost 2 weeks over.
But actually, they are transferred here for breastfeeding establishment.
Yeah.
So I don't know like how long that takes, sir. So how like discharge about the word
That's not.
discharge, I don't know whether we
This
could
is not,
use
but
here.
the baby has come out of a procedure successfully. So that we can
Yes. Ah,
well,
yeah, congratulating on that. Appreciating that.
yeah, yeah,
Yeah.
that we
Mm.
can do rather than
Mm.
congratulating for the baby because it's already 2 weeks. So
Yes.
the
You can
newborn,
say you are a brave mother. You have like baby has undergone so much and you are there to take care of the baby, something like that.
yeah, that would have been better. Yeah. Okay, Dr.
Okay, sir.
Saima, something to add, Dr. Saima? You raised your hand.
Sir, when mother was asking, should I stay in the hospital? And then what should be the answer? Not for decolonization, but for other purpose, until and unless baby feel well.
Yeah. So how long will be the baby in the hospital? So for the medical condition. So here we are keeping the baby for breastfeeding. Once the baby is fine, feeding well, and the baby is gaining weight, and all the doctors are confident, we will discharge you. So that will
Okay,
be.
sir. So basically, for decolonization, there is no need to stay in the
We
hospital.
don't.
And
Yeah, we don't see.
okay,
We don't admit for
and
decolonization.
suppose sir, we already started decolonization and it's just past 2 or 3 days, so we can discharge without completing for decolonization for 5 days.
If you are sure 3 days, no, so then we can keep in the isolation and discharge. So that also is there. Or 5 days you can because decolonization even they can go home and continue. So it's I think that the consultant can take a call on that. But as such, if the baby is continuing for a time, so you have to decolonize because
Once it is started, we have to complete it either in hospital or at home.
yeah, because we cannot give partial treatment, right? So 5 days we have to do.
But before sir, you said if you are discharging, no need for decolonization.
Doctor?
But before you said if you are discharging, and then there is
That's
no
what.
need for decolonization.
Yeah, that's what you when the baby you are doing a swab and the baby is about to be discharged today and you have the report 1 day before like that, no? So then we need not decolonize. The baby can go home.
Okay.
Okay, doctor. So any other doubts? So I think here we are building the rapport. She is getting angry, so you're going to reassure that James is not affected or not sick. You're going to tell the difference between colonization and infection. And each time you are going to say that you understand the way how she feels. So those lines are very important. So each time when
Yes,
she
sir.
agree, you have to say it must feel tough. I can understand how it's must be tough that if the baby is moving from one place to another, and when you are about to get discharged and something is popping up. But let me tell that it is not a setback. It's just it it's just the procedure, the time we have to go through, and that's why the baby is in isolation. Okay, and
Okay.
isolation is not for the baby. It's not a punishment for the baby. So that also we have to tell. It is mainly that it can spread to other babies who might be fragile, so they might not withstand this bug. So that is the reason why we are isolating. And you have to talk about the precautions. So here we will be taking care in the same manner like any other baby. We will be feeding, we will be taking care, cuddling, and all will be the same, except the nurses will have some barrier protection. They will be wearing the gown and gloves. And you also can do the same care, but except you have to do the hand hygiene before and after properly. And actually, you have to also tell that previously there was a scenario where the baby was with five babies, I think, no, in that scenario, previous.
Yeah.
So those babies also we will be screening for this colony.
Monitoring. Okay.
Right? And I think in the protocol, mother also should be screened because mother is also a caregiver. So mother will also be screened. So there also she might get angry. So now you are telling that I am responsible. So it's not you being responsible, but this organism is such a way that it spreads from one person to another person when handling. So we will be checking for it. It is recommended to check for you also, so that we can tell.
Okay.
And the protocol you are going to tell. So how long we will be doing and swabbing frequency and all. And finally, while summarizing, you have to tell that at present he is doing very well, and good that we picked up early and we can decolonize. So we are going to do this procedure mainly because it can spread to other babies, or sometimes even it can get into the baby. So we will be monitoring for that whether the baby gets infection or not. So that we will be monitoring regularly.
Okay.
Any other doubts, Doctor? We'll move on to another. Okay. So who wants to do the next chapter? It's a video station.
Can I do, sir?
Yeah, Dr. Anumatu, you can. Okay, doctor. So you take 3 minutes time. So here is a scenario will go like here is a 4-month-old baby.
Sir, this is a idea. Okay.
Video station.
Okay. Okay.
So 4-month-old baby with concerns of losing milestones or concerns of abnormal movement. So a short scenario will be there outside, and then you have to see the video. Take 3 minutes time to prepare.
Some onion, and we're gonna make refried soybeans.
James. James, no. James.
refried soybeans, refried edamame.
James. James, no. James.
A little coriander. And again, you can do something little like this. Kids love getting involved, right? So we're gonna cook that down, and then real simple. And I love the balance of that. A little bit of smoky flavor with the cumin, a little bit so simple. Then we're gonna throw this into a blender. Yummy. All right. And what we're gonna do is just real quickly, we're gonna buzz this up.
Okay, doctor.
Okay, sir.
Okay.
Sir,
So what are your
sir,
observations?
sir, in this video, I can see this 4-month-old baby lying down on the floor, most probably in a home setting, with repeated brief episodes of flexion, adduction, then extension, and followed by crying. There is that is evident in the video. And other than that, the baby does not have any dysmorphism. Not the baby not seemingly in distress. No other devices are attached. So this most probably from this video with the background of history of development regression. This can be infantile spasm.
What else will you ask in the history, doctor?
In the history, I will ask in the history of onset of this moment, how since how long this moment is present, and any preceding. I will ask a detail antenatal, natal, and postnatal history. Any antenatally diagnosed any soft lesions are there. Any antenatally diagnosed lesions are there. Then natal history, I will ask the history of any delayed crying, any evidence of ischemic encephalopathy. And postnatally, I will look for the other hypopigmented patches around the body. These all things I will look for, sir.
Okay, doctor. So what will you ask in the examination?
In the examination, I will look head to foot. I will do a detailed neurological examination, head to foot examination. I will assess any then we will look for any active macules. I will examine the cardiology, to look for any lesions of cardiac rhabdomyoma. Then in this age, then I will screen the neurologic. I will do ultrasound, neurosonogram of head or MRI to look for brain tubercles. Later in the USG abdomen, with I will look for features of renal angiomyolipoma. But in this stage, we can't see the shagreen patches. It is evident only in the later stage, in the adolescent period. Okay.
So what's your differential diagnosis?
Sir, my differentials differentials in the background of development regression will be West syndrome. Other one is hypoischemic encephalopathy. then other metabolic disorders. Then I will look for any relation to feeding. I will consider like gastroesophageal reflex, a startle reflex, exaggerated startle. These all, and any hypoglycemic symptoms. All these symptoms I will consider. I will DD. I will consider.
Okay, in this, what will be your topmost differential?
This can be in the background of development regression. It can be West syndrome, sir.
Okay, doctor. So, with this background, what investigations you want to do?
Preferably in the first line investigation, I will send a basic electrolytes, to look for a serum to rule out hypoglycemia. I will do RBS, then serum calcium, then other sodium potassium. Then I will do a EEG to look for features of this like hypsarrhythmia. Then I will do if there is hypsarrhythmia, most probably it is West syndrome. Then I will do an MRI, screening MRI to look for any brain tubercles. And then an echo also to rule to know whether there is any cardiac rhabdomyoma.
Okay, doctor. And how are you going to manage?
In the say if there is a West syndrome, sir, I will immediately. It is an urgent medical emergency. I will immediately start. Then I will consult my consultant pediatrician. Involve my consultant pediatrician as well as a neurologist. Then I will start levigabatrin plus steroids along with the steroids for the control of seizures. I will review any repeat EEG after 3 weeks. If it is not responding to the first line, then I will, and there are repeated episodes. And then there can be chance like mTOR inhibitor therapy. So many of the cases will not intractile seizures. In that case, we have to consider epilepsy surgery also.
Okay, so who are the multidisciplinary team you will be involved?
Sir, consult a pediatrician, neurologist, then developmental pediatrician, cardiologist. There is a renal angiomyoma lipoma. We can involve nephrologist also. We can for this we have to involve social service for any financial support. Genetist to know the pattern.
What are the side effects of the vigabatrin?
Vigabatrin.
Okay, actually time up.
Sir.
Okay, Dr. Anu Martin, how you did?
Flow should be improved. Even I scattered things I know. I have to little more coordinate and tell it in a structured way.
Yeah, structured way. Actually, important points almost everyone knows. So almost everyone knows that it is infantile spasm. It is the structure which they expect. So that maybe you can improve upon. So others can give your feedback. What all she can add.
I
Sir,
think, sir,
how
the
to
treatment.
describe? Sir, how to describe it? The seizures? Can you please tell?
Yeah. So you have to talk about the scenario. So what is the setting? So I can see a 4-month-old child, and what is the build? So the D's first. So he's appears well built. He's not dysmorphic. He's not in distress, and it appears to be a home setting. Then you can say I can see 3 episodes of child doing the flexion. So initially the flexion of the lower limb and the upper limb, followed by extension of the upper limb and episodes of crying. And in between, the child is staring. Actually, the child is not doing that eye contact. So when you look properly, no, so the child is not having the eye contact. It was just blank staring was there. So it is happening in clusters. So I would like to give a differential diagnosis for abnormal movement of the baby. So like that you start. Then they might ask you what will you ask in the history, then what will you ask in the examination. So like that. So, so slowly start with, try to talk about all the things. So what is the setting and what are the devices and how is the child looking. Then describe the event, okay, and try to give a big umbrella term. So maybe here abnormal movement, that will be the umbrella term. Then keep a differential diagnosis in mind. So I think here in the differential diagnosis, one is obvious. So the infantile spasm with regression, then the West syndrome. Then it could be some benign things also you have to keep. So it could be a benign myoclonus or an exaggerated startle, or as doctor said, that feeding relation. So Sandifer syndrome you can keep, or it could be a epilepsy alone. It could be a myoclonic epilepsy or other epileptic encephalopathies. So these will be your differential diagnosis. So based on that, you have to ask in the history and examination. Okay. So any
Sir,
other? Huh.
when there is a background information given that there has been some delay or some concerns regarding the development, can we still give the benign causes in this case?
Yeah, we can because they will expect just in the below the DD you keep it in the below, and you can say it's unlikely with the background. So like that you tell. So, but giving a DD is important. So maybe you can tell in the background of developmental delay, it is unlikely to be benign myoclonus. So like that you can tell.
Okay, sir.
Sir, not benign
Huh.
myoclonic. Myoclonic epilepsy, myoclonic jerks can be there, no, sir. Otherwise,
Yeah, the
not
the
deep
regular
yeah,
myoclonic epilepsy.
yeah. So because
Myoclonic epilepsy. Yeah,
the
that
sudden attacks,
DD.
that can be kept as DD, yeah.
Yeah, myoclonic epilepsy we can give DD.
Yeah.
So
Okay.
infantile spasm, West syndrome, myoclonic epilepsy. Also, a child can, it could be an exaggerated startle also, but with the background of developmental delay, it is unlikely. So like that we can tell. Okay. And maybe Dr. Anu Martin, you can work on a bit more in the detail of the history and all. For
Yes,
example,
sir.
one is the onset course duration and what makes it worse. So I think that question we can ask, especially whether it is in any part of the day. So usually when the child wakes up, it happens. So any part of the day is it worsening, and what happens before. So it's a abnormal movement, no. So what happens before, during the episode, and after the episode, any loss of consciousness, any staring, any uprolling of eyeball, any apnea. So like that, is it this first time or is it happening on a recurrent basis? And any abnormal movement, any video recording also available, so you have to check back with other video recordings. Then in your differential diagnosis, tuberous sclerosis, so any skin lesion is there or not. I think most important, Dr. Arnu, you missed on the any regression in milestones are there or not in the history. So you have to ask that. So what is happening to the development? Is the development, is there any regression in the milestone is happening or not? So then it becomes West syndrome. So you have your EEG findings with regression, or else it's just a infantile spasm. So any skin stigmata, so I think that you asked, but you didn't tell that any regression in the milestones. So that is very important. Then some elaboration of the etiology. So I think here the perinatal history is very important. I would look into the perinatal history. I would look into whether there was any gestational diabetes mellitus, any hypoglycemia, child cried immediately after birth, or a child needed any resuscitation, any fever, and any meningitis like history is there or not. So those perinatal history exploration is very important. Similarly, it's a genetic etiology. So any family member, anybody else having similar condition, so that we could have asked. And if Sandifer syndrome is in the DD, so what is the relation to the feeding? So that we could have asked. So some more elaborations I felt it's important. Very important is the developmental regression. So that don't miss.
Okay, sir.
Yeah. Then when it comes to examination, so always start with the standard airway, breathing, circulation, vitals, how is the sensorium. So that part you always ask. Sometimes head size might be an issue here. So how is the head circumference, so that we can check. Then a proper neurological examination, so that you are going to do. Then dermatological examination for the skin lesions, and I would also look for other things if it's there or not, like chagrin patch. As you say, age is a issue, but I will look for it. But a proper dermatological evaluation of all the macules, and if wood lamp is there, I would look into that also, so that you can tell. Then a proper developmental assessment is very important. And to complete, I will complete with the cardiac examination and abdominal examination. So abdominal mass also is there. So you do all the examination relevant to that. Okay. Then they will be asking, so maybe even the vision and fundus. So sometimes hematomas are there. So fundus examination also you can add. So that is this. Okay. Then you're going to give a differential diagnosis. In the top differential will be infantile spasm and tuberous sclerosis. And the examiner might lead you to it, or he might ask you, okay, assume that it has infantile spasm and West syndrome. So how are you going to investigate? So I think investigation, you told everything. So that was good that you did all the baseline investigation for any seizure. So that I liked. So always look for the glucose, calcium, and electrolytes. Then relevant to this, I would for the seizure, I would do the EEG. I am looking for the hips arrhythmia pattern, so that you are going to tell. Then MRI brain and other ECG, echo, and ultrasound abdomen. So what is hips arrhythmia pattern? They might ask you, so that you have to tell. Then maybe you could have added the genetic testing, doctor. Tuberous sclerosis.
Okay, sir.
So genetic testing maybe, so that you could have had. And hearing and vision assessment. So hearing and vision assessment we can add. Then treatment, maybe you are combining together both, I think, no? Vigabatrin and steroid. So maybe if it is tuberous sclerosis, then vigabatrin to start with. And if it is West syndrome, then I would go for steroids or ACTH. So ACTH and steroid plus pyridoxine. And if it is tuberous sclerosis, we straight away go with vigabatrin. And maybe if not responding, then you can combine and see. And after 2 weeks of therapy, you're going to look back. So if the child is on steroid, after 2 weeks of therapy, you're going to again check the EEG and see whether improvement is there or not. And then if improvement is there, you're going to taper down the steroids. And you can add pyridoxine also along with that. Then the multidisciplinary team, you're going to talk about all. So maybe the geneticist you add, and also the physiotherapy and occupational therapists, because development will be an issue. Okay. And I think that's all. So maybe the side effects. So be vigabatrin, I think you didn't tell the visual field
Yes, sir.
normality. So visual field constriction. Actually, it's difficult to assess that for an infant. So maybe you have to counsel that actually. Child can have visual field constriction, and it's difficult to assess that also. So the testing is not reliable. So that you have to tell. And ACTH also, the side effects almost like the steroid only. So you will be checking for the BP, monitor for the infection risk, then the electrolytes and glucose, so those things. Okay. Okay, doctor. So any other doubts?
Sir, this ACTH
No,
is
thank you.
all for uh, sir, tuberous sclerosis. If it is like if there are complexes of tuberous sclerosis that lesions are there, we can start ACTH.
No, for tuberous sclerosis, vigabatrin, because it's a
Okay.
syndrome. It's a syndrome. But the West syndrome, due to all the other things, no, suppose the child is having severe birth asphyxia or hypoglycemia, then West syndrome. So there you can go with the ACTH or steroid. Okay. But if it is a syndrome, I think tuberous sclerosis, drug of choice is vigabatrin. Start with. Okay, doctor. I think Dr. Nitin saying visual evoked potential in infants. So, okay, you can say it's not reliable, but options are there. We can go for visual evoked potentials. Okay. Okay, doctor. So, if everything fine, we will move on to the development part. So, who wants to do the development? History, one person do, and examination, one can.
May I can do sir development?
Yeah, doctor. You want to do the assessment part?
Okay, sir.
Okay. And who wants to take the history?
I can take it.
Yeah, Dr. Kiran can do the history. Okay, doctor. So I will show you the scenario. Take 3 minutes of your time, doctor. Please.
Yes, sir.
Okay, doctor.
Okay. Sure. So I'll enter the room. I'll introduce myself. Hello, this is Dr. Kiran. Hope I'm speaking to Sarah, mother of 2.5-year-old Leah.
Yeah, doctor. Yeah, you can call me.
So, Sarah, okay. I have come here to address your concerns. So you can tell me about your concerns regarding Leah.
Yeah, doctor. Leah is not walking or not speaking properly, doctor. She is now almost 2.5 years.
Hmm. Okay, she's not walking. So she since when did you notice that she's not walking?
It has been there since starting itself, doctor.
Okay. So do you have any regarding concerns that the skills she has got previously and now she has lost it? Any regression like that?
No, doctor. She's slow.
She is
Slowly
slowly.
it's improving actually, but she's very slow.
She is very slow, right? Okay. And coming to that, can you explain me regarding her look? How does she look? Does she look like you or his father?
Yeah, she looks like me only, doctor.
Yeah. And how's the head size? Does it look big?
Head size is a bit small only, doctor.
Bit small. Okay. And may I know any other concerns? Like, did she have any fits anytime?
Yeah, doctor. She has fits and she is on medications. I think this phenobarbital something.
Phenobarbital. So, can you explain me regarding that something? Or when did she have that first fit?
From birth, at birth itself, she had, doctor, and
She,
after that, we are giving properly. Maybe once or twice in between, she had some fits,
she
but
once or
it's
twice.
controlled.
Okay, fine. And any abnormal movement she have you noticed?
No, doctor. Other than this, no problem.
Any behavior, abnormal behavior have you noticed anytime?
I feel yeah, she's a bit crying often. She keeps crying often. She's a bit irritable, I would say.
Irritable. And is there any like hand twisting movement or head banging? Is there anything like that?
No, doctor.
No, right? Okay, is there any problem with the hearing or the vision?
Yeah, doctor. She has problem hearing. She didn't pass her hearing, and they we have to talk loudly, and they said
Hmm.
that she needs some surgery for that. She is
Okay,
currently in the hearing aid only. And
okay,
vision also, she had a problem, doctor. She was operated at 9 months for cataract, actually.
okay, sure. Okay, okay. Sorry to hear that. And how's about her speech? How many, what does she tell her name?
No, doctor. Uh, she only tells mama, papa like that only.
Oh, mama, papa. And does he, and coming to that, does she tell the need of any or toilet use? Or does she tell need of
You're not
using toilet?
audible. You're not audible.
Using toilet now? Now
Uh,
is it audible?
yeah.
Does she tell the need of toilet?
No, doctor. She only points to her needs. She
Okay,
she just passes urine just like that. But whenever she is
okay.
thirsty and all, she points to that.
Points to that. And does she follow any commands getting the cup from outside and all that? That
Yeah, doctor. Yeah.
she
She she follows
one
simple commands. She can follow. Yeah.
she can follow, right? Okay, good to know that. So coming to her, this thing, is she on a special team? Any special team of doctors?
Yeah, doctor. We have been showing to multiple doctors. We are the neuro doctor, eye doctor, and therapies also the physiotherapy, occupational therapy. We are showing, doctor.
That must be a pretty tough on you. Okay, so can I tell any operations apart from the cataract operation? Any other operations done?
That only, doctor. And we are waiting for the hearing for that operation, but still funding has not come.
Not come. Okay, so coming to and let me ask about your pregnancy. How was your daily scans? Can you explain me regarding that?
Yeah, it went well only, but just they said that she was small.
She was small.
Yeah,
Okay. And don't mind me asking this. It's a protein procedure. Had you had a smoking, alcohol, or any drugs during your pregnancy?
no, doctor, I didn't do any alcohol or smoking.
Okay, thanks for the information. And is there any history of fever and rash during your pregnancy?
Yeah, doctor, I remember I had some fever and rash.
Fever and rash.
Yeah.
Okay. Okay. And did you get admitted for that?
No, doctor. So I just showed to the doctors and took medicines.
And was it a term delivery or 9 months? Sorry,
Uh,
9 months.
a bit early, doctor. 1 month early was born.
1 month early.
He was small actually. Weight was
May I know
only.
the reason? What reasons doctors told for early delivery?
Um, because weight was small and child was small. Uh, the fluid, na? So the fluid was less. So
Less.
they took for the.
Was it a cesarean?
Yes, doctor, cesarean.
Cesarean. Okay. And after that, how many days did it stay? Did Leah stayed in NICU?
Yeah, she didn't cry actually, and she
Oh,
was in an ICU for almost 10 days. She had
10 days.
fits also. She had
Hmm.
jaundice. She was admitted for phototherapy, for light therapy.
Okay. Was she on any did any doctor tell about any brain bleed or stomach bleed at that time?
No, doctor, no bleed.
No
Six
bleed.
and a half minutes over, doctor.
Okay. And after 10 days, was she discharged home?
Yeah, doctor. Yeah.
And after that, any heel prick test was done?
Heel prick test was done, doctor. It was fine.
Okay.
Only the hearing was a problem, and
Problem.
for eyes also the cataract was there.
Was a problem. And the hip examination was done at that time?
Yeah, it was fine only.
Okay, okay. So coming back to your family, so may I know how many members are there in your family?
Yeah, me and my husband and one more elder child.
Hope,
He
yeah.
he is almost now 7 years. I think he is fine, doctor.
Okay. Are you and your husband related before marriage?
No, doctor, we are not related.
Okay. So, and how many, you have told one sibling, elder one. So sorry asking this, but it's a routine procedure. Is there any history of abortions previously?
No, doctor.
And are you both working?
No, doctor. I'm at home. My husband is also a daily wage worker only.
Okay. How many languages are spoken at home? May I know?
One language only.
One language, right? So it must have been a heavy toll on you. So may I know the economic support, anything you're getting from anywhere?
It's kind of very tough, doctor. We have to depend on the government, and it's we cannot leave the job and go also. And now for the surgery, for the hearing surgery also, we have to wait for the funding. So we are
And
unable to go to all the therapies also regularly.
it must be on a mental stress also. How's the situation at the family currently?
Yeah, doctor, we are kind of upset that Leah is she is not able to uh, do all this. She's delayed.
So, and did you give
You are not audible, doctor.
all the jabs has been given? Jabs.
Yeah, doctor. Yeah, yeah, doctor. It's
And
9 minutes. You can summarize.
okay, thank you. Thank you. Today I got opportunity to ask history from Sarah, mother of 2.5 year Leah. with history of fits since birth and a cataract operation and hearing aid with positive history of preterm delivery with oligohydramnios and birth asphyxia and in follow up with multiple team of doctors and uh, with social and a language delay, probably 1.5 years, 1.5 to 18 months to 24 months. So I'd like to go with the examination.
So what is the developmental age, doctor?
Developmental age, my social age comes around to 16 to 18 months, sir, and the language age also comes 16 to 18 months.
Okay, doctor. Okay, doctor. So before moving on to the assessment part, any feedbacks with the history? First of all, how you did, Dr. Kiran?
Actually, I just a bit fumbled in social and language history because I had so
Suddenly
much.
your voice goes up, Doctor. Suddenly goes up.
I just fumbled in a language and the social history because I had to cover the other parts. So I could have taken 1 or 2 points in extra in language and social part.
Yeah, just one question you asked, I think, right?
Yes, yes, yes.
So better uh, some more depth you could have gone.
Yes, sir.
Yeah. And anybody else wants to add to the history, but development history is always going to be a bit tight. So you get only 9 minutes. So you have to be keep rushing. Okay. So any other inputs? Yeah, sympathy. So I think anytime when she tells something, I know it must be really tough. I can understand how difficult it will be. So that and finally a question about the impact. So you can ask about how is it impacting. I think he did ask, but after that you have to try to empathize. So that is the moment to empathize. So I know it must be really tough, and I will try to arrange the help. I will try to arrange the funding by liaising with the social worker. So something you have to tell. So,
Yes, sir.
right. Okay. So, so I think it's a norm whenever you are asking questions, whenever she tells something uh, bad related to the child's health or anything. So you be spontaneous to say, I'm sorry to hear that. I'm sorry. And I know it must be really tough. So that sympathy words you can try to put. Yeah.
Yes.
Any other feedback anybody wants to? Yeah, Dr. Prasanjit Das is asking about any heart disease. Yeah, I think it's a torch infection, right? So system screening, you can be very narrow with your system screening. So you don't have any time to ask. So maybe relevant to the torch infection, as he says, maybe a word about is there any heart problem? Did doctor tell anything related to the heart? So that we could have asked. That is one point.
So
Yeah.
when she says that she had fever and rash, we should ask which trimester she had it, because the organogenesis gets affected mainly in the first trimester.
Okay. Yeah. So which part of the pregnancy you got the fever with the rash? So that in the initial part, in the initial first month, I had doctor. So like that it will come. Yeah, you can definitely ask. So that is a nice point. Okay. And whenever you are into the motor, Dr. Kiran, make sure that you say, is there any difference between the any weakness on the right side or the left side? So try to
Yes, sir.
ask a question related to that. So make sure that you're not dealing with some hemiparesis sort of thing. Okay.
Yes, sir.
Worsening, you asked about the worsening, so that is there. And maybe hemiparesis also you try to screen in the history. Okay.
Yes, sir.
Yeah, Dr. Jaya was saying language age is 9 to 10 months. So I think the age is an issue. So you said it's around everything around 18 months, right?
Yes, sir.
18 months. But maybe you have to split into receptive and expressive.
Yes, sir.
So expressive is only bisyllables. So bisyllables, mama, dada will be 9 months, as Dr. Jaya said. Um, mama, dada will be 9 months. But simple commands, so that will go into 1.5 years. So the expressive will be 1.5 years. Like receptive. Receptive will be 1.5 years, but expressive is only 9 months because bisyllables. Then social, yeah, Dr. Shaheen has raised the hand. Thanks, Dr. Jay.
Sir, I want to ask if our task is to do the motor assessment, can we ask about the this hemiparesis in the history questions? Is there because that we have to assess?
It is the developmental assessment. Na? So you don't ask the development question, walking and all. But weakness we can ask no in history.
Okay.
Why we should not ask weakness history? No? So weakness history you can ask in the history. Is there any weakness on any one side of the limb? That is not development. No? So development,
Hmm.
the child walking, sitting, so that will be development. But weakness we can ask. And once you know that weakness is there, then you will be more confident when you are doing the assessment part. So that is the reason. So make sure that you ask that whether the development is delayed or regression, whether it is only delay or regression. So that you have to ask whether any one side is affected or not, and how about other domains. So that also you initially you can ask how about his speaking and all. I think here he told straight away, the mom said that he's also not speaking properly. So that is there. Yeah.
So
Any other?
in summary, Dr. Kiran has taken the history very well, but I think in the summary he missed the point of the antenatal history that mother gave, the fever and the rash. That would have been very important regarding the diagnosis of this etiological diagnosis of this of his condition of a
If he
condition.
has missed, then that is important while summarizing. So better we usually have a sheet of paper, no? So better write down all the positives alone at least when you have the sheet of paper, so that you don't forget while talking. Talk. So the summary will be like here is a 2.5-year-old who is not able to. So go as you took, not able to walk or speak well, and it has been there since infancy and it is slow to improve. She also has vision and hearing problems and small head, and the fever and rash is there, so that we have to tell. And maybe the teams you didn't inquire actually, no, whether the compliance with the teams. So that we have to ask. She is seeing multiple teams, but is it regular or not? So it is not regular because of financial and transport issues were there. Then perinatally, the baby was born premature and the baby didn't cry. The baby had to stay for 10 days. Child had seizures, and because of the seizures, child is on anticonvulsants. So those all you are going to tell. Then the developmental history based on the development, the age you are going to tell. And with this, probably the child has a global developmental delay. And I would like to further evaluate by doing the assessment. Like tell and close.
Okay.
Okay, doctor. So, Dr. Shamsusma,
Yes, sir.
so are you ready with the assessment part? Yeah,
Yes,
Dr.
sir.
Shaheen wanted to say something before me.
Sir, I can ask after his assessment. No issues.
Okay. Okay, Dr. Shamsuman, you can start your assessment.
Okay. I have gelled my hand and have taken the permission prior and entered the room in a very sensitive way, and we look what the child is doing current.
Yeah. So child is sitting and playing with a toy.
Okay. I will see any device is attached or not.
Yeah, she is wearing specs, and she is also having some hearing aid.
Okay. I will observe any dysmorphic features present or not.
Yeah, there are no dysmorphic features.
Okay.
Only the head is small.
Okay. I will go behind. Her name was
Doctor?
the child's name was
Child's name, I think Leah.
Leah. Go behind her and whisper Leah, Leah in both ears. Is she is able to hear or not?
No, she is not responding.
Okay, I will loudly call her by name, Leah, and is she is responding or not?
Yeah. Then she is responding.
Okay, I observe her eyes and see the alignment of the eyes, and also observe any squint or strabismus present or not.
Yeah, squint is present.
Okay. Then I will ask Leah, can you stand for me, please, and walk for me?
Yeah.
E-
She is unable to stand on her own.
Okay, I will see uh, any special shoes or anything is wearing or not.
There are no special shoes.
Okay, then I will ask Leah, if she is able to sit, can you sit, Leah, for me, please?
Yeah, she can sit.
Okay, that's great. Then I will see her tone in both lower limbs and upper limbs. Is there any spasticity or rigidity present or not?
Yeah, tone is
With proper
increased. Tone is increased more on the lower limbs.
okay, and I will ask Leah. Leah, can you please stand with me, and I will uh, give her support if she is able to with support stand and walk or not.
Yeah, she can stand with support.
Okay, with support she is able to walk or not.
Yeah, she can. She is not able to walk with support also.
Okay, then I will give her a ball, and Leah, can you please kick the ball like me, and I will observe if she is using her both legs
No,
or not.
she cannot kick the ball.
Okay, then I will ask Leah if she is able to throw a ball or not.
No, she is not able to throw the ball.
Okay, is Leah is able to catch a ball or not?
No.
Okay, then I will uh, uh, assess her fine motor. I will take some uh, cards, crayon, paper, baby scissors, book from the table, and I will give Leah, and will make tower by cubes. I will make a tower of 9 to 9 cubes, and is she able to Leah, can you please make a tower for me? Is she able to make a tower with cubes or not, and how much cubes she is able to use?
Yeah, she can build a tower of 4 cubes.
Okay. And I will ask Leah, can you please take this crayon and draw a circle for me? And I will draw a circle. Is she able to hold the crayon and make the circle or not?
She is only able to scribble.
Okay. And I observe how she is holding the crayon.
Yeah, she is holding like this.
Okay. Then I ask Leah, can you please turn the book pages for me? I will turn one by one page and give the book Leah how many pages she is able to turn, one by one or at multiple pages.
She is able to turn 2 pages at a time.
Okay. Okay, great. Okay, Leah, you are doing a great. Okay, and I will give her a baby scissor with proper permission from her mother, and she is able to hold the scissor or not.
No, I don't think it is safe, doctor.
Okay, that's great. Thank you. And I will give Leah some board and a simple shapes. Firstly, she is able to put the shapes into the board or not.
She is only randomly playing with the shapes, doctor.
Okay, that's great. Okay, Leah, fine. And I will then keep the boards the behind me, and I will take the large beads. Is she able to thread the large beads or not?
No, doctor. She tries to put it in the mouth and play.
Okay. And I will see if she is able to use both hands or any weakness in any part of the hands or not.
Yeah,
right and left hand.
Yeah, both the hands she is able to use.
Okay. That's great. And finally, I will give thanks, Leah. Leah, thanks a lot. You have done a great. And today, I got opportunity to assess Leah's gross and fine motor development in the Leah has wearing spectacles and also wearing hearing aids, and also is her head size is small. I want to plot her occipital frontal circumference in the proper OFC chart. And in the assessment of the gross motor, I want to give Leah 15 months to 18 months, because Leah demonstrated today standing on support, and not demonstrated with support walking, or kicking a ball, or and on fine motor assessment, I want to give her developmental age 15 15 months to 18 months, because Leah today demonstrated the scribble only, and also demonstrated making a tower of 4 cubes, and not demonstrated turning 2 pages of books, and not demonstrated threading a large bead, or putting the simple shapes on the board.
So what is your assessment, doctor? So is it a global developmental delay or isolated?
Yes, global developmental delay.
So what are the causes of delay in this child?
So from history and also there is spasticity present on lower limbs, and so I my differential is from history and assessment. This a case of congenital rubella syndrome, most probably congenital rubella syndrome, and I have also some differentials such as maybe a case of hypoxic ischemic encephalopathy with neonatal jaundice, also may the cerebral palsy.
Okay, doctor. What else are contributing to the delay?
Because the child had history of during pregnancy, mother was suffering from fever and rash, and also microcephaly, and also premature delivery, and also suffering of neonatal convulsions, along with ICU support, and also history of hypoxic ischemic encephalopathy. So, congenital rubella syndrome with ischemic encephalopathy and prematurity
What
and microcephaly fits. All these are contributing factors of global developmental delay.
so what investigations will you do?
So I want to do through developmental assessment, and with through history, and targeted systemic assessment, and want to do some in rubella antibody test, and also want to do the MRI of brain, EEG, and also other basic investigations such as thyroid function test, and random blood sugar, serum creatinine, uh, and also hearing and ophthalmological assessment.
Okay, how are you going to manage, doctor?
I will want to manage this child under the umbrella of multidisciplinary team, involvement of the ophthalmologist and ENT specialist, and pediatric neurologist, general pediatrician, developmental pediatrician, and speech and language therapist, and physiotherapist, occupational therapist, and also social worker, and
Okay. So what is the role of SALT therapist, doctor? Speech and language therapist?
speech and language therapist will help the child acquiring the for proper language making, word making, and receptive and expressive language development.
Time up actually. Okay. Okay, doctor. Time up actually. So
Thank you, sir.
Conference month, how you did?
Sir, actually, our Nepal exam cancelled.
Yeah.
Yes, so I practiced after a long period, because I became busy with my residency course in pediatric cardiology. I am year 3 phase B in pediatric cardiology resident.
Okay.
So during my other medical tasks, whenever I get time, I want to practice.
Okay. So any dates they have given for Nepal?
No, sir. Actually, they did not give any specific date.
That must be
Actually, sir, it is a devastating for us, because delay is a very much uncertain for us.
must be tough actually, because the practice
Yes.
everywhere we
And in my situation, I am very suffering very much difficulties, because I am getting very less time to cope up, because I have to learn eco, cath lab, and ward and cardiac surgery and lots of
So with
wards.
that, actually, with that loss in touch, still you are actually able to do well. So everyone has said that only, even in the group also, well done. And thank you. So anybody else wants to give feedback regarding his assessment? Anything which he could have done, added?
During gross motor assessment, when he
Yeah,
was
Dr. Priya, tell Dr.
yeah, so in gross motor assessment, when he was doing when the child was not able to walk or just he is able to stand, do we need to do the 180-degree maneuver as well?
Yeah. So now we know that I think that is the point. So now that we know that the child is below 1 year, so
Right.
maybe we have to look into the infant development. So if you do that, then it will be added points. But if I feel if the child is in the 6 months range, definitely it's better to do the 180-degree flip. But here the child is able to stand with some support, so it's coming somewhere around uh, 9 months plus. So the child is able to stand with support, so that will be 9 months, right? So sitting without support and stand with support, so 9 months. But child is not able to stand without support, so the child is not more than 12 months. So 9 to 12 months. So there maybe you can add. It will be an added points. So if you do the 180-degree flip, at least what we can do is here we can lift the child and see that scissoring part you would have picked up, okay, and put the baby on the prone position, what the child is doing, so that we can do. Because actually, Dr. Samsuzman, you didn't check for the crawling, creeping actually.
Yes, sir.
So you could have done that. So what you could have done is you could have, as Dr. Priya was saying, you can one is you can lift and see, and you can pull and see. So pull to sit. So the child is able to sit, but when the child is lying down, you can, instead of saying it as 180-degree, you can do all those things. You can say when the child is lying down, how is the child? What is the child doing? So that you can do. And when you are pulling, how is the child while pulling? Pull to sit. And when the child is sitting, how is the child sitting? Is it straight back or is it a curved back? So that you can do. Then when you are holding up, how is the child? So there the scissoring would have happened. And when you put in the prone position, make sure the child is lifting well above with the extended arms, so that you can check. And give a ball. So keep a ball at a distance and see whether the child is crawling and creeping. So I think that one point they will be expecting, because here you didn't check for the, you check for the sitting and you check for the standing, but you didn't check for the crawling and creeping. So I think that we could have done. Okay.
Okay, sir.
Any other feedbacks anybody wants to add?
Sir, also in gross motor, though the chronological age is 2 years, so
Yeah.
we have to do like if the child is just able to stand with support, then do we need to really ask about whether the child is able to kick the ball or while like running, like while standing, or when we are like just know that the child is just able to stand with support?
Yeah, I think logically speaking, the child is not able to stand alone independently. So then I think kicking ball we can avoid. But if the child is standing independently, then you can offer the ball, because child is around 2.5 years, I think. But here, even standing itself is difficult. The child needs support. Then how is the child going to kick the ball, right? So I think we need not ask the kicking the ball, as Dr. Priya said. Yeah.
Sir, I have a question that if we got a discrepancy in the left and right, do we need to ask separately the left and right if there is an hemiplegia or and give a different age?
Yeah. So I think here, Dr. Shamsusman, I expected you to, you asked about both hands at the end. So ask it at the beginning itself. So when it comes to the crayon, no, so I will give initially itself, I will give the paper and the crayon and see whether the child is receiving with both the hands. Okay. So make
Okay, sir.
sure that there is no hemiparesis, because hemiparesis then it becomes a different ball game. Okay. And each item you tell how is the child holding. So crayon, how is the child holding? Cube, how is the child? Pincer grasp, I think you didn't check. So how is the child holding the pincer grasp? And here, when I give the object, the child might not reach out for the object because vision is an issue here. So the child might have some difficulty. And regarding the question to Dr. Shaheen, so I would say, suppose the child has hemiparesis, okay, Dr. Shaheen,
Hmm.
has hemiparesis. So one side is totally normal and one side is weak, okay. So now why did they give this scenario to you? So it's a developmental case, no?
Hmm.
Why did they give the hemiparesis to you? So is it to say that he has a normal development or there is some delay in the development? Because it's in a development station, right? So
Hmm.
are you to say that child is 5 years, child is having normal development 5 years? So maybe they are not given for that, no. So
Hmm.
they have given to say that there is decreased abilities on the other side. You understand? So that's why they have given hemiparesis. Otherwise, right hand is normal. The child is able to build the tower for a 4-year-old, means 12 cubes. The child is doing well, so there is no delay. Then why should they give it for you in the exam? So that is
Hmm.
the reason. So at least, but at least demonstrate the discrepancy. You show the discrepancy. So you give the cubes for both the hands. See how is the child building the tower, and you say that, sir, there is a discrepancy in the abilities of right side and the left side. So right side the child is able to do this. Left side the child is able to do that of a 1.5-year-old child. Right side of a 4-year child. But development, I would like to give the best ability as the developmental age. I would like to give it as 4 years. So like that. So test, but do the testing for both sides. So that is my suggestion. But you cannot have a two different developmental age. Development is single only. No, it is overall it is the same. So you need not give a different developmental age for one side and different developmental age. But you can say that there is a discrepancy in the abilities of both sides. One side, this much the child is able to do. One side the child is able to do this. But I would like to give a overall the developmental age as the best developmental age as 4 years. So like that's my
Hmm.
suggestion.
So,
Okay, sir. Okay.
sir,
And
here I have a query. Like when we are testing and there is an obvious discrepancy on both the sides, we do check it by giving the cubes. So in that case, should we go ahead and check the impaired hand for all the other functions, like for putting the shapes or drawing or building, or
Yeah,
should we
try out.
just
Try out, try out, doctor. Try out. Give
we
them.
should try?
Uh, quickly you do. Definitely that side child will not be able to do. Many times they will say only some two cubes, only some scribbling, so like that. Once you know that the scribbling only, no, then you need
Hmm.
not go with beads and all.
Hmm.
So it's around 1.5 years. So close down the scissor and beads on that side. So don't give everything. So, but
Okay.
the primitive scribbling cubes, then this what else? Board, board,
Board and
book,
book
cube,
turning.
and cube. That's all. So maybe cube, beads, and scissor you avoid. Okay.
Yeah, but shapes we can tell them.
Shapes you can see. Can do.
Okay, sir.
And also
mm,
here one more issue is with the handedness. So even if the child is suppose right-handed, child become hemiparetic on the right hand. Now you are looking into the left hand. So left hand might not be writing all the shapes because that was not his dominant hand, no. So it might be a bit less. So that also you have to tell actually. While explaining, you can tell.
Sir, I have another query that it has
Yeah.
been taught in the mock in the Chennai that we cannot ask the questions related to the fine motor, like how many cubes of tower he can make and can he
In the
draw.
in the history, na? In the
Yeah,
history.
in the history. So what sort of questions we need to ask? So when I asked to the mentor, he said that you can ask that how can he like doing a shoe tie the shoelaces? Can he do the buttoning and unbuttoning? But my query is that if the sir, our task is to do the social assessment, these all milestone also comes in the social. So we cannot ask this question. I think in the related to the fine motor.
Yeah, that see logically what madam was saying was correct only. See, you cannot go and straight away and ask how many cubes he can build. That is a correct question only logically.
Yes, I agree.
But the problem is our role player is trained with a script. Okay, and in that script we cannot create some task and check. The role player might not know that. Okay, and many times the role player will tell cubes. If you ask, he will tell he can build a tower of. He will not say, "No, doctor, I don't know." So cubes is something is very. So it usually it will be there in the script. So that's why we are asking. So if you ask if the role player says, then you got your age, right?
Yes, yes.
If not, but at least drawing and all, he will tell. If I give a crayon, what all he can draw. So can he draw a circle and all? Cubes might be difficult. If they tell,
Hmm.
you will get the age. If he doesn't tell, no problem. You go to the next. You give the crayon and see what he can draw. I think that much is good enough. Okay.
Okay, sir. Thank
So
you.
drawing will be good. Mostly it will be there in the script because if we create some capabilities like madam was saying, you open the tab, see whether he is able to open the tab, whether he is closing the door and all for the fine motor. Yeah, that is good. But if I ask that, will the role player will answer that? And what ages we don't have a chart for the ages, right? So for that, so that's why better we have that standard cubes crayon, no? So the same we ask, and if they say you got your age, if they don't say at least drawing, you should be able to say.
Okay, sir. Thank you so much.
And here in this thing, I think the handedness is very important, and whenever you give how is the child grasping pincer grasp. So when it comes to the cubes, you can do that. And if you feel that it is inappropriate for the age, you need not ask. Suppose here the child is 2.5 years, so we need not give the beats also because beats starts from 3 years, right? Large beat starts from 3 years, so maybe we need not give the large beats here. Okay. And regarding Dr. Shamsusman, regarding the developmental age, so you what age you told? You told something around 15 to 18 months for cross motor.
Yes, sir. 15 to 18 years will not be correct. It will be 9 months to 12 months.
Yeah, yeah. So that only that was the one correction I had to. So I think you can all practice that the infant
Doc-
development. You read the
Doctor,
Dr. Munir.
uh, yes, yes. Sir, in this scenario, the task was motor assessment, but this doctor went to check the hearing also. So, is it necessary to
But
check the hearing in this
yeah,
patient?
yeah, we need not check doctor. But when something is really obvious, no, I think you have to check. So here in the history, you know that he has a hearing problem. They are into the cochlear implant, and whatever assessment you are doing, it is relevant how you talk. So I think hearing in this scenario, it's worth asking because otherwise motor we usually check the vision only. But here he doesn't hear. We know in the history itself he doesn't hear. There is a hearing aid, and you don't know whether he will understand your task also. So better you check. You take a moment and assess the hearing, because otherwise he
Right,
will
sir.
not obey the task. No. So better you check. Okay, doctor. So I think
Sir, can you tell how we check the vision again
yeah.
in assessment?
So vision, no. So with whatever items you have. So one is you show the crayon or the cubes. See how is he fixing at the fixing at the object. So whether he is looking at the object intently or not. So that is very important. So you show some bright object, the cubes or this crayon, bright crayon, no. So whether he is fixing at the object, then whether he is reaching out for the object. So that two things you can do. So whether he is reaching out properly for the object. So here the child may not reach at the object because of the vision problem. So you give it and then he holds it. So that's like, so fixing and reaching. And if in infant development they talk about moving, following the object. So whether the child is tracking object. So initially up to 90-degree, then up to 180-degree. So 6 weeks. So 3 months they track up to 180-degree. So moving up, fixing and tracking the objects and reaching out for the objects. So like that. Okay, doctor. So I think before wrapping up, I would say that prepare for the infant development also, because most of the nowadays they have understood that you are very good at doing the cubes, crayons, scissors. So they are giving a bit 9 months to 12 months, 6 months to 9 months, this developmental milestones. So the moment, so how to identify that you should understand. So the moment the child is not able to stand with support, the child is only able to sit. So then it becomes infant development. So you have to talk about sitting, then crawling, okay. Then as Dr. Priya said, you know the age now. Sitting and crawling, based on that itself, you know the age. But you have to spend at least 3 minutes. So I think there the 180-degree flip helps. So there, how is the child lying in supine, then pull to sit, then vertical suspension, then prone position. So that all will be there in the infant development. So read those so that you take 3 minutes for your gross motor, then the fine motor. And fine motor, again, fine motor, same thing. You give the cube, what is the child doing with the cube? So the child is holding with the pincer grasp. When you build the tower, child is building the tower, then it becomes 15 months plus. The child is throwing the cubes. The child is not building any tower. So it becomes 1 year, the casting comes. And below that, the child is not building any tower. So the child is going below 1 year. So there you have to look into the pincer grasp, then object permanence. Okay. Then give a rattle and see whether bidextrous grasp is there or unidextrous grasp is there. So fine motor also you have to go down if the child is unable to build a tower of cubes. Okay. Okay, doctor. So any doubts, or it's almost 12?
And sir, what about speech, language, and social?
Regarding assessment.
Yeah, how we will assess we have to go below 1 year, like you told in gross and fine.
So my say is most of the gross motor and fine motor happens in 1 year. Okay. So they can give you 1 year assessment in gross motor and fine motor. But when you look into the speech, see, there is hardly the child speaks anything up to 1 year. So maybe they might not give you the speech and language. It's not that easy because child is not able to speak even 2 or 3 words. That's all. 1 year, 2 or 3 words. So you will be having only some monosyllable, bisyllable, cooing. That's all. So I think speech you will finish off. You will not even have 1 minute and above. So they might not give you speech and language. So
Okay, thank you.
Mostly it's the gross and fine motor.
Sir, can you tell what we will say? What is the role of salt?
Yeah. So depending on the scenario. So suppose you have a neurodegenerative, there is feeding difficulties. So then swallowing and feeding will be their important role. But here there is a hearing problem, no? So the child might not speak very well. So even if you give the speech therapy, the child might not speak. So pre-verbal skills, the child is only doing bisyllables. Why bisyllables? Because there is a hearing issue. So there you can teach some pre-verbal skills or some alternative communication methods. So those things you can stress upon. So augmentative and alternative communication methods can be taught, and speech therapy. So child so not only the speech, but the pre-verbal skills, sign languages. So those things can be taught. Okay, doctor. So it was nice interacting with you all. So keep preparing. So we will meet you again soon. And meanwhile, try to download our app. So the pre-recorded videos. This video also we will upload in the app. Okay, I will share you the link. Thank you, doctor.
Thank you, sir. App or sir, YouTube channel.
YouTube also I will share, doctor.
Yes, sir.
Thank you.
Thank you, sir.